Hi, everyone. Welcome to our weekly webinar today. Thanks for joining us. We'll go on ahead and get started since it's 2 o'clock. So my name is Dr. Tina Lewandowski. I'm the Director of Engagement. And today we have Dr. Russell Swerdlow with us. Dr. Swerdlow is a professor at the University of Kansas Medical School, as well as our director of the KU ADRC. He gained his undergraduate and graduate MD degrees from NYU and subsequently trained as a neurologist and Alzheimer's specialist at the University of Virginia. Dr. Swerdlow's research focus is on brain energy metabolism and his role in Alzheimer's disease, for which he has earned multiple awards. I wanted to let everyone know that you have the option to enable closed captioning. Just select the button with the CC at the bottom of the screen and make sure to enable the captioning. Just a friendly reminder to keep your microphones on mute. And if you have any questions, you can type them in the chat or press the raise hand button and we will call on you. As always, we will have the recording available on our website within 24 hours. Dr. Swerdlow, thank you again for coming back and having a question and answer session for us. I know everybody thinks this is such a treat to have an expert answer their questions. So thank you for your time today. I will turn it over to you.
Thanks. Well, the treat for me as well. This is the highlight of my day. So I always enjoy doing these, the doctor is in sessions. So I was, thank you all for those who send questions in ahead of time. I'll run through a list of it's 12 questions that were sent in, and then there should be time to address other questions that come in via chat. So just to jump right in. So the first question I have here is about the link between hearing loss and dementia and/or Alzheimer's. So yes, it's true. There has been a paper showing that there's an association with hearing loss and Alzheimer's. It doesn't mean that hearing loss is causing Alzheimer's. I suspect it. There could be a lot of reasons why less robust hearing associates with Alzheimer's. Meaning that when I say associate, that someone who has Alzheimer's may have a slightly higher risk of having hearing loss. And the bottom line is, for those of you who have hearing loss, I wouldn't worry about it. I don't think it means that you have to think that, oh, I have hearing loss. Does that mean that I'm about to get Alzheimer's, or is this the first sign of my Alzheimer's? I would reassure against that. The next question I have is, I've read something about the relationship between Alzheimer's and our gut. Can you speak about that? Yeah, so what that's largely about is the fact that within our gastrointestinal tracts, there are a lot of bacteria that live. These are not bad bacteria. These are bacteria that we need for our gastrointestinal system to function. Everyone has their gut bacteria. Like this is the whole probiotics industry. But the thought is that these bacteria, they can metabolize, for example, of the foods you eat or drugs that you take, and some of those breakdown products from the bacteria may then get absorbed into the body, and maybe that can affect how the brain performs. This is what we call each person has their own microbiome. And their microbiome, at least on a theoretical level, may affect how other organs function. The brain certainly would not be privileged in this respect, but it's something that investigators are looking at, including people here at KU. We have investigators in our center who are looking at relationships between someone's gut microbiome and things like memory and Alzheimer's. The third question I have here is Gotucola good for brain health? I'm not quite sure how to pronounce it. Gotucola or Gotucola. It's I know about this by Gotucola is it's an Eastern herbal medicine, and the more scientific name for it actually is something called Centella asiatica. That's the name of the herb. And in Chinese medicine, there's been some interest in it for, I don't know, like millennia, for using it to treat issues of memory, amongst many other things. And it's sold here in the U.S. as a dietary or nutritional supplement. There is some interest in the Alzheimer's field about it. There's a group out in Portland that thinks it actually is it actually boosts mitochondrial function, and they published some papers to this effect. It's not something that we've studied here, but the Alzheimer's Association recently funded a clinical trial of Centella asiatica, or this Gotucola, in Alzheimer's. And actually, I'm going to be on that study's review board. So at least I'll get to hear every 6 months or so about how that study is going, especially vis-a-vis the safety issues. So is it good for brain health? The answer is, I don't know, or I don't think anyone knows. But there actually is going to be a clinical study to look at that question. The fourth question I have here comes from someone who says, I just learned I have hypothyroid disease. How might that increase my chances of developing dementia? And what I would say is that if you take thyroid replacement therapy, in other words, if which I'm sure you will be, or you are, as long as you're supplementing your thyroid hormone, it should not increase your risks of developing dementia. Okay, fifth question number 5, is there a self-administered cognitive test I can take for Alzheimer's? And the answer is yeah, there are a lot of them. One of the ones that I think looks particularly good is something called the SAGE test, SAGE. It's an acronym that stands for self-administered geriatric. I forget what E stands for, but it's something that you can download off the internet. If you type in to your browser SAGE, SAGE, cognitive test, it will open to a website where you can download it. It's actually not a bad test. It's like 3 pages long, but it's something that someone can self-administer to themselves. Here's a question: are there other medications that work better than donepezil, and if so, what are they? So, I would just say that having treated people with Alzheimer's for over 25 years, sort of my go-to medicine is still donepezil. I feel you get, it's a very cheap medicine. It's usually very well tolerated. I think the risk to benefit ratio is very positive. It's very inexpensive, and so I haven't seen anything yet that's more powerful or potent. So I guess the answer to that is that I haven't seen any other medications that work better than donepezil. But of course, we're going to get better things, and that's a question that comes up later. So someone asked about a new book called Life Force, and I'm not familiar with this book. It sounds like it says here that there were some interesting new drugs and treatments to help Alzheimer's disease, and so I'm unfamiliar with what the book discussed, but in terms of new treatments or drugs, what's going to be coming in the next decade? I suspect that over the next decade, we're going to get incrementally better at treating the disease. Right now, I have to say the bar is pretty low. Anything that helps is going to generate interest, even if it's just a little bit of help. And I suspect what will happen is we'll come up with probably a couple of things that help to a real small amount. We'll start using them collectively to maybe get a little more bang for the buck from that. And then certainly I would say within in 10 to 20 years, where I think that everything that we're learning now is really going to start to be paying off in terms of how we treat things. I'd like to say it's going to be quicker than this, but I think 10 years from now we'll be treating it better than we are, maybe not as good as we'd like to be, but the farther we get away, the more we move forward from that, the fuzzier my crystal ball gets. But I do think that in 20 years, 30 years, we'll really have a transformational grasp of this and how to fix this problem. Okay, number 8. You have talked about good things. All of us have talked about good things to do to protect the brain, to promote brain health. Are there some common things some of us might be doing that would be worsening our chances of getting Alzheimer's disease? I can give you a very clear-cut answer to that. It's if you do the opposite of the things that we think might help a brain, if you do the opposite of those, those are things that might hurt a brain. So, we talk about eating a healthy diet to help the brain. Obviously, if you eat an abusive diet, it's probably not going to help. It's probably going to hurt the brain. We talk about being physically active to help protect the brain. If you're the more sedentary you are, probably that's going to have an adverse impact on the brain. So everything is kind of like a switch, right? If you dial it in the good direction, things get good. If you dial it in the bad direction, things get less good. Okay. Someone wanted to know, does water with crystal light added count as water for the daily intake? And my answer is it works for me. I would count that as water intake for the day. Okay, the 10th question I have is, are we using something called the A-beta 42/40 ratio in our patient workups, or as a screening tool for study participants? So what that's about for people who aren't familiar with that is it falls into a category of what we call biomarkers. It's things that we can measure, either using an imaging technique, or measuring something, let's say in the blood or in the spinal fluid, where we can measure a level of something that gives us some indication of does someone have Alzheimer's, or the processes related to Alzheimer's going on. And one of those biomarkers that's generated a lot of interest is the something called the A-beta 42/40 ratio. So A-beta is the protein that collects in the plaques, and the Beta-amyloid can have different lengths to it. It can be 40 amino acids long or 42 amino acids long. And those people in people with Alzheimer's or in the process of developing Alzheimer's, the amount of A beta 42 that's present, in whatever fluid we're measuring, whether it's spinal fluid or even in the blood, that the level of the A beta 42 protein goes down more than the A beta 40 protein goes down. So the ratio changes. And there are a lot of groups, including ours, that are using that to try to, as sort of a biomarker of where someone is in the Alzheimer's timeline. So yes, we do use this test. We use it mostly in research right now. For example, everyone in the Alzheimer's Research Center clinical cohort is getting these biomarker studies done on them. And especially with the blood-based biomarkers, we're starting to use them more to screen patients for clinical trials. But we offer them in the clinic as well. Right now, it's most common, mostly when we're getting these biomarkers in the clinic, we're doing it through the spinal fluid. But I think, in future years, it's going to become more common to do it using blood. But we, is this going to open things up for a blood test for Alzheimer's disease? Yeah, it's a little more complicated than that, because people can be perfectly normal, clinically, and have a positive biomarker test. And just because you have a positive biomarker test doesn't mean that if you're doing fine, it doesn't mean that you're ever going to clinically be diagnosed with Alzheimer's. But this is a very active area of Alzheimer's research, and we're very actively engaged in it here at our center. There's a question here: what is the current diagnostic algorithm? And what I would say is that the diagnostic algorithm, on a very broad level, we all kind of use the same algorithm, which I guess would be, first get the story, and then and then do an exam, and then put everything together to try and say, yeah, does this seem to be Alzheimer's disease or not? The biomarkers that we now use add another level it gives us something else that we can consider doing. So the again, the first thing is to try and get the story of why the patient is, why the patient or the family member thinks that something is wrong. And really what we're trying to boil down to is, the first question is there a change in the person's memory or other thinking, what we call cognition, that is apparent to either the patient or to someone that knows them? And usually, by the fact that they're there in the clinic with us means that the answer is yes to that, right? That's how they ended up in the clinic in the first place, because someone thought there was a problem. And the next question is, how deep is the problem? Is it kind of like a nuisance kind of thing? Does it make you anxious, but not really interfere with how one gets through the day? Or does it interfere with how one gets through the day? That's an important question for us, because that's going to that helps define what sandbox we put someone in as we're thinking about things. And then our exam is to look to see, looking to see whether we can objectively detect correlative evidence that someone's memory has declined. And we do that on two levels. We try to determine whether someone has declined relative to their expected peer group performance, or has someone declined relative to what we suspect their earlier level of performance was. So yeah, if we think that, if the story is, someone has a progressive decline in cognition that's affecting activities of daily living, it could be, Alzheimer's is certainly going to be on the differential diagnosis. There's some other things that we our doctor's guidelines say we should do, like we should take at some point pictures of the brain should be taken, and at some point blood work should be done to look for things like, let's say, a low vitamin B12 level, or to make sure the blood counts are in the right place. And that's kind of been a long-standing way to do it. Now, when we see patients, we also consider whether there would be any utility to doing a biomarker test. And at this point in time, we're mostly advocating a biomarker test when after we're done getting the story and done doing the exam. There's still a lot of uncertainty over what might be going on. So we're using it in the cases that are less straightforward, and they can be helpful. So that's kind of the general algorithm. Although the different clinicians in the clinic all go about this in slightly different ways. Okay, and then the next question is, what, if any, current clinical trials show promise? And the way I'm going to wiggle out of this question is to say that any trial, until it's returned a negative result, has promise. That's why we're doing the trial. I think I wouldn't be surprised if some things that are being tested now in some of our clinical trials go on to maybe get some degree of approval, and we start to end up using them in the clinic. I certainly hope that's going to be the case. I certainly feel that things that are being tested in the clinic now will also teach us better ways to treat Alzheimer's. A great example would be, I think, the diet study, the TDAD study. That TDAD stands for Therapeutic Diets in Alzheimer's Disease. And the goal is not to have all the Alzheimer's patients in the world utilize a particular diet. It's basically to answer the question of, if there's a particular diet that may benefit people more, then it's very important to people like me, because we can then figure out what it is about that diet that is maybe helping people. And then once we have that knowledge, then we can use that knowledge to create drugs that will recreate what the diets do, only stronger, more directly, and without having to go through the trouble of dieting. Okay, so now it looks like there's been a bunch of questions coming in. Let me see what I can get through in the next 10 minutes or so. Yeah, I love this question. Will the beta-amyloid controversy, including the science articles, have any influence on your research direction? Not me. The perspective I would give back on the latest big story, for some of you who may not heard, the bottom line is, the press is recently made a lot of noise about a study that was published in 2006 that basically, made the case that amyloid, a particular kind of beta amyloid, was driving Alzheimer's disease. And it turns out that a lot of the data in that paper were likely faked. And so the press is asking, does this really change the direction that Alzheimer's disease is going in? And I would just say, I never really believed that paper was important to begin with. I always thought it was a bit of a distraction. The reason why is that a lot of our research uses what we call models. It's very hard to study mechanisms in living people. So scientists create what we call models to study very discrete molecular questions. And the thing you got to keep in mind is all models are wrong. Some models are useful, but this was even back in 2006, and I was on NIH review panels when this paper came out, and I was in the room when scientists were discussing whether the grants to do this kind of research were being discussed. And my sense was, who cares? This is studying an artifact in an irrelevant model. And so my guess is it may be it certainly makes people want to be cynical and critical of what they're reading. But I would just say you should always be cynical and critical with what you're reading. So yeah, okay. Oh, and can you explain the article in Science? So hopefully I just explained what that was all about. It was really quite amazing, So people like inside stories. So the inside story I can give you, sort of, being there in the kitchen when this was being cooked up, was there were two groups of scientists. There are two labs, one in Minnesota and one in Boston, that were fighting over something called beta-amyloid oligomers. And one group said, we think that A-beta oligomers are the toxin that causes Alzheimer's disease. And we think that it's the oligomer that has two beta amyloids linked together, what we call a dimer. That was the Boston group. And the group in Minnesota said, no, we think it's a group of 6 A-betas linked together. So a hexamer oligomer. And these groups were duking it out, calling each other names, and one group saying, no, you're wrong, blah, blah, blah. And but the paper that seems to have been faked was the paper that said the 6 oligomers, the 6 oligomer beta amyloid was the Alzheimer's toxin. And they were basing this research off of research that was being done in a special mouse that only they had. And my sense was, who cares? This is like in a mouse. No one can find this in humans, and I'm not particularly impressed by that line of research. But that's what that story was about. And so it comes out 16 years later that some sleuths are going through journal articles. And it's kind of a convoluted story about how someone ended up looking at that major paper. But someone did end up looking at that paper, and I said, wait, hold on a second. It looks like some of the data here were doctored. And well, the rest is in the newspaper. Okay, what about galantamine? Yes, so obviously, if I say the name of a drug that I kind of like, I got to be careful because everyone's going to say, "Oh, Swerdlow said donepezil is the best." I need to clarify that, which is donepezil is one of a group of really 3 medications. They all kind of do the same thing. One is called donepezil, DONEPEZIL, and then there's one, but there's another. There are 2 others. One is called galantamine, and the other is called rivastigmine. And the rivastigmine is a patch. So usually what I do is, all these medicines are pretty much equivalent at the efficacy level. Usually the first one that I try to prescribe to people, if they're not on one of these medicines, is donepezil. And I do that because it's the least expensive medication. And then, most people tolerate donepezil just fine, but if they don't, then I turn to one of the other ones. And the next one I go to typically is galantamine. Why? Because it's a pill, and I think it's a little easier for people to use pills and patches, although some people prefer a patch. And then if people have a problem with galantamine, then I usually go to a rivastigmine patch. But different clinicians will go in different orders, and that's all fine. It's all good. They all work about the same. But for people that have a diagnosis of Alzheimer's, I like to see them on either donepezil, galantamine, or rivastigmine, because I do think, having treated Alzheimer's for really 30 plus years, that I think people do better with these medicines than without. Okay. I've heard sugar being called, how bad is sugar for brain health? I think, think of it this way. The rest of the body takes care of the brain. And as long as your body is able to handle sugar, I don't think that sugar is going to be bad for the brain. So, all things are in moderation. Obviously, let's say for someone with diabetes, they may not want to shoot their blood sugar up too high, or let it go too low. But but the important thing is that the levels in the body are not out of whack. And if they're not out of whack, probably the brain is not going to be irritated by that. Okay, let me see here. If you had 2 TIAs but now take meds and all signs look great, can you participate in any of your trials? I was told there might be a problem knowing what changes are from what. No, I would definitely say go be screened. Don't count yourself out. All the trials have their own specific rules, but certainly in some of the trials that I'm involved with, having had a TIA in and of itself is not going to preclude someone from being in a trial. Obviously, the devil's in the details of the trial and the details of the TIAs. But no, what I would absolutely say is that if you're interested in participating in research and you have a history of TIAs, don't let that count you out, because for probably most trials, it's not going to. Okay. If sugar is bad for the brain, what are the alternatives, such as Splenda, Truvia, etc.? I would just clarify that I don't think that sugar is bad for the brain if the body can handle the sugar. If your body can't handle sugar, maybe things like Splenda and Truvia might be helpful alternatives to get the sweetness you like without knocking your blood sugars out of whack. Okay. Has the beta-amyloid controversy and recent science articles influenced your research directions? I think I answered that one. And what about Memantine? I like, Memantine definitely has a place as well in the management of Alzheimer's disease. It's actually been approved for people who are in moderate to severe stages of Alzheimer's. Although clinicians tend to have a more liberal cutoff for when to use it. So I usually will start adding it on when people are starting to get more towards the late mild stage of Alzheimer's. So now I'm a little more liberal in using it, but it's not the first thing I turn to, especially if I'm diagnosing someone who's in the mild or very mild stages. There's just more data that you get more bang from the buck in those stages from the cholinesterase inhibitors, which include donepezil, galantamine, and rivastigmine. Okay, and maybe I'll make this the last question. Have incidence of Alzheimer's increased, or do you think we have just gotten better at diagnosis in conjunction with living longer? Yeah, I don't think that these days people are more likely to get Alzheimer's than they were in past decades. Quite the contrary. There are some data to say that maybe now, the risk of an individual's risk of getting Alzheimer's is maybe less than it was 20, 30 years ago. But certainly more people are being diagnosed with that, and that's due to some of the reasons that have been that are being noted in this question. So part of it is that people are living longer. The best way to not get Alzheimer's is to die young. So if you're going to live a long time, the longer you plan on living, the higher, just by getting older, that's going to contribute to one's risk. The other things too is, yes, the definitions of Alzheimer's are changing. And if you define Alzheimer's disease very narrowly, let's say by a plaque entangled dementia, then that's a more restrictive definition than, let's say, the diagnosis or criteria that say, yeah, plaques and tangles with or without dementia, which is, and the most liberal definition would be just having plaques. And so, this is a real debate in the field. What are we going to call Alzheimer's disease? And so what I would say is that what we call it today, we may be calling it something different, next year or 10 years or 20 years from now. And the other thing that I think is a great teaching point that I would leave you all with is that just because we put a name on something doesn't mean we really understand it. So, you can probably call Alzheimer's disease a dozen different things. You can call it a dozen different names. What wouldn't affect, kind of how I think about it, which is what's driving this problem. We sometimes we get a little too caught up on names and to the point that just because we have a name for it, we must really, really, really understand it. And that's not necessarily the case. Names help us, guide us how we're going to think about things, but they don't necessarily give us the answers that we need. Oh, okay. And one last thing. Can I go back over when you add the drug Memantine? So I usually the first thing I do with a new Alzheimer's diagnosis is to make sure they're on a cholinesterase inhibitor. And then I'll follow the patient, and hopefully they'll stabilize for some time, but we do know that as time goes on, they're very likely going to continue to show decline at some point. And then when it becomes clear that the trajectory of decline has returned, then I start looking for a kind of a point where I think there's been enough change to go ahead and initiate the Memantine. And where do I draw that line? I draw that line on talking to the patient and the family and getting a sense of how things are going. And then I also, in my examination, I also do some clinical scales that I could objectively apply to the question. And for example, something called the mini mental state exam. When someone's mini mental state exam score goes to 23 or below, that's usually a point where I'm thinking, yeah, maybe this is a good time to start the Memantine. So I can't thank you enough for all these questions. You guys kept me rambling today. So I congratulate you all and thank you all. Hope it was helpful. Thanks.
Dr. Swerdlow, as always, thank you so much, and we hope to have you back again soon. So thank you for answering all of our questions. Those of you who sent questions in early, thank you. We appreciate that as well. So I want to let everyone know that the recording will be available soon. And information about our next presentation can be found in your My Alliance Monday email. And again, same time next week, Thursday at 2 o'clock, we will have